First of all, I'd like to thank Dr. Shah for the invitation. It's a lot of fun coming here to speak, and I especially like talking to multidisciplinary groups. So there are nurses, there are APPs, there are physicians, and there are probably pharmacists here, and I think that makes it a lot more fun to speak to this type of a group. Of course, I love speaking to physicians as well. We have them here. I want to talk very briefly about multiple myeloma. We have a limited amount of time. I will be following along with the slides. I've changed a few, and a few have dropped out, as you'll notice, and a few are not on the slide packet. My apologies for that. Like many slide presenters, we play with them until the last minute. So I'm from Seattle at the University of Washington, the Seattle Cancer Care Alliance, and the Hutch. This is our group. 5 people in the myeloma group, and in the center is Dr. Benzinger, who's our senior member. Pam Becker is also been around for a long time practicing multiple myeloma and acute leukemia. Damian Green and Nick Berwick are both young investigators in the laboratory looking for new ways to treat and hopefully someday cure multiple myeloma, and I'm down there on the bottom right. I'm really a clinician who does clinical trials at the Seattle Cancer Care Alliance. I have no conflicts of interest to declare, and I think the learning goals are really to just review generally diagnosis of multiple myeloma, treatment approaches, the role of stem cell transplant, and perhaps some new drugs. What I want to focus on here is just that when we do, I think everyone in the room who deals with multiple myeloma is aware of the standard workup, something that is really not too much of a problem any longer, but getting cytogenetics, standard metaphase cytogenetics, and multiple myeloma FISH is important. It's becoming increasingly important because we're beginning to practice personalized medicine for patients with multiple myeloma. Therapy is beginning to be adapted according to your cytogenetic risks, and I'll talk to that as we go along. But don't forget to get cytogenetics and FISH. This is the myelomas, the Mayo Clinic's classification for cytogenetic risk, which I often refer to. Not every group agrees completely on this, but in general, this is widely used, with 70 to 80% of patients being in the standard risk category on the right. These are patients with either no changes in their cytogenetics, trisomies, or the other 2 translocations, which are rarely seen. Then there are the intermediate and high-risk groups, which should be treated somewhat differently. In particular, 414, which is seen in about 10 to 15% of patients. Complex karyotypes, which are much less common. And then the ultra-high-risk myeloma, patients with del17p, 1416, and 1420. And we would tailor our approach to these patients in 2014 and 2015. We can start to tailor our approach depending on their cytogenetics. Now, everyone who takes care of myeloma is aware of the CRAB criteria, so I'm not going to belabor that, and that's hypercalcemia, renal insufficiency, anemia, and bony lesions. Those have been around for 10, 20, 30 years. They've been somewhat modified in recent decades, but things have been pretty stable in terms of what constitutes the CRAB criteria. But finally, what's been a sleepy topic for a long time in multiple myeloma, there's a big change, and it's probably one of the, or there's suggestions of a big change, and it's probably one of the most interesting things, at least to me, going on in myeloma right now. And what that is for patients with smoldering myeloma, patients with asymptomatic myeloma. For years, what we've done is watch them until they have CRAB criteria, until they have a bone fracture, until they have renal failure or anemia. And now, many investigators around the world have shown that you can classify patients with smoldering myeloma into patients who are at very high risk for developing symptomatic myeloma in the near future, and patients who are at low risk and don't have to be treated. And because of that, they're talking about biomarkers, and these are referred to as MDE, or myeloma-defining events. It's CRAB criteria plus using new biomarkers to define who should be treated. And those are the 3 that are currently being suggested are for patients with more than equal to 60% or more plasma cells in their bone marrow, or at very high risk for progressing in the near future. Patients with a serum free light chain ratio greater than or equal to 100, and it's the involved over the uninvolved. So if your lambda light chains are what's elevated, then you divide lambda by kappa. If it's kappa over lambda. But if the ratio is greater than or equal to 100, high risk for progressing. And patients who have more than one focal lesion by MRI. And why MRI, as I'll talk about a little bit, MRI is more sensitive at seeing early destruction to the bone. And so long before you can see a hole by plain skeletal x-rays, which are still a gold standard screening tool for most patients, long before you see bony destruction, you can see it with an MRI. So this CRAB is going to be turning into MDE, or myeloma defining events, or it's likely to, I should say, because not everyone agrees about this quite yet. And the idea is that for patients who have this, there is near inevitable development of symptomatic myeloma within 2 years. So if you have a 90% or so chance of developing symptomatic myeloma in a year or 2 years, should you wait until you have kidney damage? The big question is, should we wait until there's kidney failure? Should we wait until there's a bony fracture? And so there's a lot of concern that we should not, which is what we've been doing for a long time. Intervene before there's end organ damage. So in a Mayo Clinic study of patients who had smoldering multiple myeloma, they looked back at several hundred patients who had smoldering myeloma and their bone marrow biopsies. Mayo Clinic has a very large database of multiple myeloma patients going back several decades because they focused in it for a long time. They found, I believe it was 30 to 40 patients who had a bone marrow with smoldering myeloma, who met the criteria for smoldering myeloma, greater than 10% plasma cells in the bone marrow, and or greater than 3 grams per deciliter of an M spike. And they noted that those patients who had 60% or more plasma cells in the bone marrow progressed within 2 years. And they had a 90% risk of progressing to, it's actually 95% risk of progressing within 2 years. And on average, they progressed within about a year. So that's pretty compelling data that anyone you see with more than 60% is going to need to be treated soon. Now, the counter argument is, where's the proof that treating them earlier actually makes a difference? Those studies haven't been done, but it's intuitive that do we need to wait, do a study where we wait until patients have bony fractures or end up on dialysis to then prove that there's a difference by treating them early. It makes a lot of logical sense. So this is one of the proposed myeloma defining events, is a high percentage of plasma cells you should consider treating. And that was the New England Journal article, and that was their recommendation. In addition, another study by the Mayo Clinic looked at 586 patients with smoldering myeloma, which is defined as greater than 10% plasma cells in the bone marrow, or an M spike of greater than 3, that they saw over a 40-year period. And they looked at patients. They have banked the serum from those patients going back decades. So they were able to measure the serum free light chain ratio in these patients. And they found that the risk of progression to multiple myeloma or light chain amyloidosis was 79% at 2 years. And the vast majority, 72 or 73% of these patients, progressed to myeloma, not to amyloid, but a small percentage progressed to amyloidosis. So overall, almost a 4 out of 5 shot at developing a serious illness within 2 years. And these are the curves, and I'm not good with the arrow here, but if you go here at 24, you can see that it's almost 80% at 2 years. So this is a second myeloma defining event, and there's a proposal, a suggestion that patients should be treated with, when they have a free light chain ratio like this. And finally, as I talked about earlier, using bone marrow MRI, a study from Germany looked at 149 patients with smoldering or asymptomatic myeloma. The current definition of that is still the same thing, 10% or greater plasma cells in the marrow, no CRAB criteria, or an SPEP greater than 3. And they found that 28% of them had focal lesions by MRI, although they had asymptomatic myeloma. The patients that had, about 15.4% of those patients had more than one focal lesion. And a focal lesion is a sort of a roundish, dark spot. Depending on how you use the attenuation on the MRI, it can be dark or light, that tells you there's early destruction to the marrow, early dense involvement with myeloma. And these were the curves. And what they saw was that at 2 years, get my little arrow going here, at 2 years there is a major difference. You can see there's about an 80% of patients who had more than one focal lesion on MRI. I'm sorry I didn't put a picture in here, I should have. Had progressed to symptomatic myeloma, anemia, renal failure, bone fracture, hypercalcemia. So based on this data, and there's a lot of other, these aren't the only studies that have this kind of outcome, but based on this data, the International Myeloma Working Group produced new recommendations just in the last month or so that patients should be treated when they have one of those 3 myeloma-defining events. Now, there's a lot of controversy and disagreement about that in our own group. There's disagreement about it. I think the more I look at the data, the more compelling I think it is. I guess what I'm going to do with patients is talk to them about the risks and benefits of treatment and follow them much more closely if they have any of these risk factors, and in some of them consider going ahead and treating early on. Another area that wasn't included in the myeloma-defining events was cytogenetics, and it turns out that the cytogenetics in smoldering myeloma, no surprise, are just as meaningful as they are in symptomatic myeloma. So patients who have 414, who have del17p, who have the 1q deletion with multiple myeloma progress much more rapidly to symptomatic myeloma. And I think over the next few years, 1 to 3 years, cytogenetics will also be included in these MDE defining events. So if you're thinking smoldering, make sure you get cytogenetics as well. So it's a new paradigm for smoldering myeloma. A small but significant percentage of patients will progress quickly, and you should consider treating them. Although this is, still going to be a lot of debate. I'm sure at ASH in a month there'll be a lot of gnashing of teeth and pulling of hair over what we should do. But I'm going to follow these patients much more closely every month. I'm going to tell them what the risks and benefits are. Sure, I'm reluctant to put somebody on treatment knowing that once you start on treatment for multiple myeloma, you basically can never stop. And younger patients are headed towards a transplant, so you have to be very thoughtful about it. But there's a lot to lose, too, if you wait for them to present in the emergency room with complete renal failure. Other things that are going to be looked at for biomarkers will be flow cytometry, looking at the number of abnormal plasma cells versus the number of normal, the levels of circulating plasma cells, the proliferative rate of bone marrow plasma cells. That's been used at Mayo for decades, but it's not used anywhere else. Cytogenetics we've talked about, and perhaps gene expression profiling can also be used to help us to predict who's going to progress and when. So it's an exciting time for this unique part of multiple myeloma. Whenever you see just a little note about using MRI for getting the smoldering myeloma, but if you see someone in whom you find what you think is a solitary plasmacytoma, it's recommended that you obtain a full body MRI because patients often have more than one plasmacytoma. So you don't want to miss it because they may have other areas that require radiation or that may have impending collapse. So a general recommendation is if there's one solitary plasmacytoma, worry about others and get a full bone marrow MRI. You could also consider a CT PET. Right now, the role of CT PET is uncertain. So it's definitely valuable in patients who may have had in the past or in whom you're suspicious that have outside of the bone or extramedullary metastasis. In late-stage myeloma, we're seeing more and more of this as patients have failed the immunomodulatory drugs and the proteasome inhibitors. Then extramedullary disease is becoming a major problem in patients who have lived longer, but now they've burned more bridges and the disease is more aggressive. I'm going to skip through this. So when you're treating multiple myeloma, so if we want to, if just think of a patient, perhaps 70 or younger, or roughly 70 or younger, potential stem cell transplant candidate who arrives in your office and needs to be treated, these are the recommendations by the National Comprehensive Cancer Network for treatment of multiple myeloma, newly diagnosed multiple myeloma. And the ones I've lined through is only because, not that they aren't justifiable, they're Category 1 recommendations, but they're not widely used in the United States as frontline. So just bortezomib and dex is generally not used, I think, because clinicians would often add Cytoxan to that regimen for Cyborg D or VCD to get more efficacy. DVD, Doxil, Velcade and dexamethasone, because of the toxicities of Doxil, and it isn't particularly effective in myeloma, isn't widely used anymore. And thalidomide, of course, isn't used very widely in the United States either. But not that there's anything wrong with it necessarily, but it does have more side effects. So our choices in the U.S. usually for a transplant-eligible patient would be Cyborg D or VCD, Revlimid, Velcade, and dexamethasone, where you're giving them both of the new drugs, so really the kitchen sink profile, the kitchen sink principle, and Lendex, which is an excellent regimen, well tolerated. All of these regimens are reasonably well tolerated. Revdex is just pills, so it's especially nice if you have patients who live a long, great distance away, if you want to simplify their regimen. And these are the response rates for these regimens. So I just want to point out that if I can get my arrow going here, here's Revdex, and this lower bar is the rate of complete remission, which is about 25%, and the overall response is about 80%, with just Revlimid and dexamethasone. And if you go over to CVD or Cyborg D, you can see that the complete response rate is maybe 10 to 15% higher. The overall response rate is a little bit higher. And then the yellow is the VGPR. And then RVD is really the best frontline regimen we have right now. We're giving all the good drugs up front. This is the best approved frontline regimen. So, and then you have a complete remission rate of about 40% and an overall response rate of roughly 100%, maybe just a little bit less. There are patients occasionally who don't respond even to RVD. And at last year's ASH, carfilzomib, Revlimid, and dex was presented, and it showed a very high rate of complete remission, over 60% with a 100% response rate. So with our new drugs, we're going to have more and more patients achieving a complete remission with induction therapy, potentially with induction therapy. So we're going to talk a little bit about transplant, but what does that mean, or what does that mean to me? In my mind, the goal for a long time has been to achieve a complete remission in multiple myeloma, and in most malignancies. That's a goal that generally equates to progression-free survival, cure, and in some diseases, and improved overall survival. So in general, our goal is a complete remission whenever we can get that. So as more people are achieving a complete remission, what does that mean for stem cell transplant? Well, as you can see, at least with, let me find my arrow, even with our best therapy, if you can get the insurance to approve RVD up front, even with our best therapy, it's still only about a little over 40% complete remission rate. Well, what about the rest of those patients? They haven't achieved a complete remission, and it's been shown again and again that complete remission is linked to improved overall survival and progression-free survival in multiple myeloma. So my approach and my way of thinking is these are the patients in particular that need a stem cell transplant so we can achieve a complete remission. We can get another log or 2 or 3 reduction in the multiple myeloma with a consolidative stem cell transplant. So if you're seeing a patient who's potentially a candidate for a stem cell transplant, when should they be referred? Many centers want to see them after 3 to 4 cycles, and that's because many transplant centers will collect stem cells quite early. Our center at the SCCA, at the Hutch, we would prefer to see them after 4 to 8 cycles. We'd like for the referring physician to treat the patient in general to best response, so you've seen a plateau. Then that's usually going to be a little bit more than 4 cycles, maybe 4 to 8 cycles. And ideally, the patient would have an M spike less than 1. I'm not referring to free light chains here, but a major reduction in free light chains. M spike less than 1, and there would be less than 10% plasma cells in the marrow. It should be 10%. So if we see somebody with more than that, we will tend to do more cytoreduction prior to stem cell collection and transplant. It doesn't mean you can't or we wouldn't do a transplant, but for our center, that's the ideal scenario. In general, you don't want to refer patients for transplant a year or 2 or 3 out, because it gets harder and harder to collect stem cells. So it's very important. It's an insurance plan for the patient to get those stem cells collected, because it can be difficult in patients who've had a lot of prior treatment. So every center around the country would like to see them early, certainly within 4 to 8 cycles. Contraindications to stem cell transplant. Renal failure is really not a contraindication. Stem cell transplant, autologous transplants done routinely in patients with renal failure. We do dose reduce the melphalan, the high-dose melphalan, to 140 milligrams. It still can be quite effective, and you can also, in some patients, reduce it to 100 milligrams per meter squared. Age is generally not a major barrier. Some centers are transplanting up to 75. I think in someone who's, if they pass the eyeball test and they look like they're 60 but they're 73, we would consider, and they live like they're 60 but they're 73, we certainly would consider stem cell transplant. So even elderly patients can get them if they're in great shape. Performance status is key. You want to have a very physically able patient who's certainly no more than an ECOG 2. The genetics are very important. Patients with high risk and intermediate risk cytogenetics should get transplanted up front. Those are the patients that need very aggressive therapy. They're going to relapse earlier. They may benefit from a transplant with a longer survival. Amyloid is not a contraindication in myeloma, and it's very common. 10 to 20% of patients with myeloma have amyloid if you look hard enough for it, secondary amyloid. A low ejection fraction, less than 40%, would be a contraindication. Pulmonary function tests are important, and a low DLCO would potentially knock a patient out. Patients without a support system may or may not be candidates. We are trying to be more liberal in our transplant criteria, and for patients who are intelligent and reliable and can take care of themselves, they don't always have to have a caregiver, as opposed to what's been done for many, many years. We're trying to liberalize that for patients who really can clearly take care of themselves. Patients with serious psychological drug or alcohol use probably are not great candidates for a transplant. So Palumbo, who's one of the lead investigators in multiple myeloma, transplant and non-transplant, from Italy, but he's one of the lead people in the world, has pointed out that one trial, where's the role of transplant in 2014 and 15, there has been a randomized trial comparing conventional chemotherapy with maintenance versus transplant with maintenance, and there was a markedly improved progression-free survival. Overall survival was not, improvements had not yet been reported in this study. There are a number of randomized trials looking at the value of stem cell transplant. And as I'm going to show you, there's about 3,000 patients are being randomized into these studies to see, should transplant be done early or at first relapse, and also what's the role of transplant. Are the new drugs so good that we don't need to do transplant, or we should only do it in relapsed patients? One of the trials is called the Nordic trial, and it treats patients with VMP and then randomizes them to either transplant or no transplant. And maintenance lenalidomide is given until progression. And then this study is being done in Seattle, and this is a study from France, Belgium, and the United States looking at RVD with or without transplant. It's a study of about 1,500 patients. Everyone gets lenalidomide maintenance, and it should definitively tell us whether or not to transplant patients when they're newly diagnosed in the first 6 to 12 months, or can we wait until the first relapse. About 50%, 30 to 50% of patients in the United States right now are having their transplant delayed. Stem cells are collected early, but transplant is delayed until first relapse by patient and physician preference. So this is becoming widely practiced around the United States, and it needs to be studied. There have been three studies, one prospective and two retrospective studies that have shown that whether you get your transplant up front or you get it at first relapse, you still preserve the survival benefit of an autologous stem cell transplant. So an autologous stem cell transplant is thought to give patients another year to a year and a half of overall survival, and this appears to be preserved whether you get a frontline or delayed transplant. The progression-free survival, however, may be less. This is just the IFM study that I mentioned that we're doing, we're participating in the Hutch. There's about 600 patients. It's going to 1,000, and patients get RVD, the best therapy available. They're then randomized to stem cell collection and then more RVD and maintenance lenalidomide, or stem cell collection, transplant, and then maintenance lenalidomide. We won't know the answer for another 2 to 3 years. We have to wait for the results of these studies. Right now, there is no clear data telling us that transplant is not the right thing to do. In fact, there's a lot of data telling us that it still provides progression-free survival and overall survival benefit for patients. The NCCN, in its most recent iteration, does continue to recommend transplant either upfront or at first relapse. I'm running out of time, so I'm going to skip ahead a little bit. In fact, I'm almost out of time. So, this is a nice graph from blood giving you an idea of where we're going with the treatment of multiple myeloma in 2015. I'll go ahead and skip ahead 2 or 3 months. And first of all would be to induce the patient. And if that's all you did is, say, give Revlimid and dexamethasone or Velcade, Cytoxan and dexamethasone, you would get some reduction in tumor bulk, this curve here. But if that's all you did, you would ultimately relapse. But if you then added to that a stem cell transplant, you can see over here on this axis is tumor bulk. If you then added a transplant, you'd get further reduction in the amount of myeloma. But if that's all you did, you would then still relapse fairly early on. If you induced, transplanted, and then gave more chemotherapy after the transplant, you'd get even further reduction in the tumor burden, but ultimately you would relapse. But if you then gave maintenance, which all of this is being done currently, perhaps over time, when you've got a very low level of myeloma, you can either have the relapse far out, 5, 6, 8 years, and or with potential changes in maintenance therapy, cure some patients, perhaps cure more patients, depending on how effective our drugs are. So we're moving towards a cure. We don't have one right now, but this is the general idea, is to treat patients on and try to push the level of myeloma as low as possible. I just want to remind you about msmart.org. It's an excellent resource when you've got 1 minute, you need a 1-minute decision guide on how to treat people with myeloma, Waldenstrom's, or amyloid. I thank the Mayo Clinic for putting this up. It's an excellent resource. I send my fellows to it. I'm going to skip through this. New agents for 2014. Well, there wasn't anything released, but some drugs that are right around the corner, and we'll be hearing about them at ASH in a month, would be elotuzumab, histone deacetylase inhibitors, and monoclonal antibodies. Elotuzumab is also a monoclonal antibody, is monoclonal antibodies against multiple myeloma. And I guess this isn't the slide that I had wanted, but I will wrap it up with this. This is a really interesting report from investigators at the Mayo Clinic looking at most of the drugs that have ever been studied in multiple myeloma. And the point of the report was that most of the drugs that have been studied have turned out to be useless, and these were hundreds of drugs. And the drugs up here in the box, these had no activity. When you gave them to human beings, nothing happened. Then, if you go down here, these are drugs anytime there's a box, there's a little tiny bit of activity. There was a little bit of a response when you gave them to human beings. And they found that you had to have somewhere between 15 and 20% shrinkage of the M spike, or decrease in the M spike, in order for the drug ever to have enough activity to be useful in clinical medicine. So their suggestion was that when we do research studies, if we don't see in phase 1 studies, the earliest studies, if we don't see at least 15 to 20% decrease in the multiple myeloma, the drug shouldn't go any further. Otherwise, it's a waste of time and energy. One of the things I found interesting about this, so if you look at this graphic, up here are these wonderful drugs we have now, lenalidomide, carfilzomib, thalidomide, pomalidomide. These are really active drugs. And this is in human beings. But look at what the most active drug ever reported is so far, is melphalan. So still, an old drug is a very active drug and may well continue to serve us as a foundation for treatment in multiple myeloma and a backbone. Thank you very much for allowing me to speak, and I look forward to hearing the rest of the speakers today.